Yeah, now we're live on YouTube. Great.
Um, do I start now,
No,
or do you have introductions?
wait. Wait, I will start.
Okay.
So first, let me put off the securities, and then you can able to share the screen, right? Okay, I'll go off. Then let me check the status once. Hello, guys. Good evening. So you're welcome to the seventh class of Basics of Cardiac Pharmacology. And before we introduce our topic, from Clemed side actually. The announcement is that Clemed has opened. Hello, I think it is visible. Okay, okay, one sec. One sec. I think I have some technical problems. One second. Yeah. So I will just share. I hope it is visible to you guys. Yeah. So announcement is that Clemed has opened the admissions for 2021, and these admissions are for the training programs for international pharmacy licensing exams. And we are now have everything in our pocket. Like we are preparing the students for Canada, PEBC, for Australia and New Zealand CAPS, and for UAE, all three exams MOH, DHA, and HAAD. And for USA, we are preparing for FPGEE. And for UK, we are preparing for pharmacy licensing exam and career guidance. So you guys can contact us on our email ID or on our phone numbers. So for the further information, for the packages and everything, so these admissions are open now, and batch is going to start in the January on 4th January 2021. Admissions are opened. So if you are paying the fees, the early bird admission is the date is 10th December 2020. So if you are paying the half of the fees before 10th December, and if you are booking your slot by paying 2,000 rupees, you may get 15% off or 15% discount on the full fee. Okay, guys. So this was the announcement. We are open for the admissions. Now I will stop sharing and let me introduce our today's speaker. So she is very special, actually, you know, because she is also from Manipal. She did PharmD in 2016 from Manipal College of Pharmaceutical Sciences, and she was the gold medalist in PharmD. Dr. Mansha, and now she is pursuing PhD in clinical pharmaceutical sciences from University of Florida College of Pharmacy, Department of Pharmacotherapy and Translational Research, PTR, Florida. And she has been the pre-doctoral research fellow at University of Florida. She's working as a teaching and graduate assistant at University of Florida College of Pharmacy. She has been the Oris Fellow in 2017, and intern Decisions Resource Group Analytics and Insights Limited in 2016. And she got many awards and recognitions like ALEC Curtis Award in November 2020. I mean this month only, from the University of Florida International Center, then travel grants for various conferences and various presentations, and she got best poster award for on his graduation division in 33rd annual research showcase, University of Florida. And she has lot of fellowships in her pocket, like gold medal for highest overall score and Grinter fellowship and WHO fellowship. She has many fellowships in her pocket. So uh, Dr. Mansha, you're welcome, and thank you for accepting our invitation to take a lecture on diuretics. Her specialty is diuretics. So thank you, Manasa.
Thank you, sir, for this wonderful introduction. And yeah, I'm happy to be part of ClearMed course.
Yeah, you can share and start the, yeah.
Yes. Okay, I'll share my screen. So can you guys see my screen now?
Yeah, visible.
Oh, cool. So yeah, I'm Manasa. I'm a fifth year PhD student with University of Florida. And I am working on thiazide diuretics, trying to identify microRNA biomarkers and pharmacogenetic biomarkers to predict response of thiazides in hypertensive patients. So I am slightly related. My work is related to diuretics. So that is why I thought I could give a lecture on diuretics. So yeah, so let's get started. So to get a brief background, we all know that the human body has 60% of water by weight, and the fluid and electrolyte homeostasis is very important to balance in the body, because any small disruption in this homeostasis can cause severe complications like arrhythmias or cerebral edema or seizures and several complications. So our body has this very complex network of pathways to balance and keep this homeostasis stable. So it uses neuronal pathways like neuronal activation of our uh, uh, thirst receptors, or hormonal activation like vasopressins and natriuretic peptides, or hemodynamic pathways, or renal pathways, so where sodium and urine water is extracted. So all of these pathways work together to form this homeostasis of fluid and electrolytes, and diuretics play a role in the renal regulation of this homeostasis. So that's where diuretics come in. So the word diuretics comes from the fact that these agents cause increased urine output. So this diuresis can be caused either by natriuresis, which means increased sodium excretion, or it can be caused by aquauresis, which is increased water excretion. So usually natriuresis happens along with aquauresis, but the opposite is not necessarily true, and we'll see why in the later slides. And the first diuretic that was discovered was in 1937, and it was a carbonic anhydrase inhibitor. And after 20 years, a more efficient diuretic that is called thiazide is discovered in 1957. Now, here is a broad classification of diuretics for us. There are high efficiency diuretics called loop diuretics, and the examples are furosemide, bumetanide, and torsemide. And there are moderate efficiency diuretics. They are called thiazides together, and they are again subclassified as the classic thiazides or thiazide-like diuretics. Let me just take a laser pointer. Yeah. So examples for thiazides are hydrochlorothiazide and bendroflumethiazide. And thiazide-like diuretics are chlorthalidone, indapamide, and metolazone. And then there are low efficiency diuretics, and there are again 3 different types of low efficiency diuretics. The first one is potassium sparing diuretics, and they can act either by aldosterone antagonism or by inhibition of the renal sodium channels. So the drugs which act by aldosterone antagonism are spironolactone and eplerenone, and the drugs which act by inhibition of renal sodium channel are triamterene and amiloride. And then there's another type of diuretics called osmotic diuretics. Example is mannitol. And then there are carbonic anhydrase inhibitors. Example, acetazolamide and dorzolamide. Now that we know all of these diuretics act on the kidney, I thought it is important for us to understand the basic biology and physiology of kidney. So our kidney has 2 important layers. The outside layer is called the renal cortex, and the inner layer is called the renal medulla. So the functional unit of a kidney is called a nephron. And there are 2 different types of nephrons, cortical nephron and the juxtamedullary nephron. So the difference between these 2 types of nephrons is that it's just the size of the nephron. The cortical nephron has a very small tube, and this nephron is completely confined to the outer layer or the renal cortex, and hence the name cortical nephron. And the juxtamedullary nephron has a very long loop that protrudes into the renal medulla. So that is why it's called the juxtamedullary nephron. Now looking at the detailed parts of a single nephron, let's start with the Bowman's capsule. It is a cup-like structure which goes around the glomerulus. Glomerulus is just a network, a mesh-like structure of capillaries that bring blood to the kidney, and the arterioles that bring blood to the kidney are called afferent arterioles, and those which take blood away from the glomerulus are called efferent arterioles. So the blood in these capillaries get filtered, and the filtrate goes into the Bowman's capsule, and then it flows through the tubule here. The first part, which is very convoluted and it's closest to the Bowman's capsule, is called the proximal convoluted tubule. And then there is a hairpin-like structure, which is called the loop of Henle. And the first part of the loop of Henle is called the descending loop of Henle, and the later part is called the ascending loop of Henle. And then there's another convoluted part, which is away from the Bowman's capsule. So it is termed as distal convoluted tubule. And then this goes and opens into the collecting duct. Now, the process of filtration has 3 different steps. First is the glomerular filtration, and then there is tubular reabsorption. So all of the electrolytes which is filtered into this tubules are reabsorbed back into the blood. And the third step is tubular secretion. So when you go along the tubule, it is the electrolytes and metabolites are again secreted into the tubule. So all of these 3 steps, filtration, reabsorption, and secretion, together will give you the final constituents of the urine. Now, the different diuretics that we have seen in the previous slides act at various different sites on this nephron, and they have different mechanisms of action. So for example, mannitol, which is osmotic diuretic, acts all along the nephron. Acetazolamide, it is a carbonic anhydrase inhibitor. It acts in the proximal part, proximal convoluted tubule. And then the loop diuretics, as the name suggests, it acts on the loop of Henle. And then there are thiazides, which act on the distal convoluted tubule, along with these potassium sparing diuretics. So here, the filtration happens, the first step, and then there's reabsorption from the tubules into the blood. And there is also tubular secretion from the blood into the tubules. Now let's talk about the mechanism of action of each of these classes. And understanding the mechanism of action is very important, because that will help you understand what indication is most suitable for that particular diuretic. Diuretics is basically a very broad class, and each of them have different mechanism of action. So, and each of them have different indications. So it's not a class as a whole. You can call each drug in this class, you can make a different class out of it, so that they act that differently. So let's start with carbonic anhydrase inhibitors. Sorry, just a second. Okay, so carbonic anhydrase, the enzyme carbonic anhydrase, as the name suggests, it causes dehydration of the carbonic acid, which is H2CO3. So that breaks down carbonic acid into water and carbon dioxide, which is reabsorbed into the system, into the cells. Again, this is rehydrated with the same enzyme into carbonic acid. So basically, carbonic anhydrase enzyme causes utilization of the bicarbonate and the hydrogen atoms, and causes its reabsorption. But when we provide the carbonic anhydrase inhibitor, the effect of carbonic anhydrase is prevented. So we cannot utilize the bicarbonate ion that is being secreted in the urine. And so the sodium along with the bicarbonate is excreted out into the urine. So natriuresis happens, and that is how it exhibits its diuretic action. So here we can see that the carbonic anhydrase inhibitors act in the proximal part of the convoluted tubule. But the excess sodium that reaches to the end of the tubule, when it reaches the ENaC transporters, or the sodium potassium transporters, what happens is it gets reabsorbed by the channel, and in turn, potassium is released into the urine or into the tubules. So enhanced sodium delivery results in the potassium loss in the collecting duct. So overall, we can see that there is a loss of sodium bicarbonate, and then there's hypokalemia. Also, because this action requires the presence of bicarbonate for it to happen, you cannot see a prolonged diuretic effect with these carbonic anhydrase inhibitors. The tolerance develops within 2 to 3 days, because there's no bicarbonate in the urine anymore for it to act. So that's how tolerance develops. Now that we understood how carbonic anhydrase inhibitors works, I believe it's easier to understand why these indications and why the toxicities happen. So carbonic anhydrase enzyme is not restricted to just the kidneys. It is present in various parts of the body. So one of the most common indications for this diuretic is glaucoma. The drugs dichlorphenamide and methazolamide are used because how it acts is that our ciliary bodies in the eye, it creates the aqueous humor by extracting the bicarbonate from the blood, and that is catalyzed by the carbonic anhydrase enzyme. So when we take the carbonic anhydrase inhibitors, this action is blocked. So it prevents the formation of the aqueous humor. And in turn, it reduces the ocular pressure. So that is why it is used in the treatment of glaucoma. And then it can also be used in the treatment of urinary alkalization. So what do you mean by urinary alkalization? You know that bicarbonate is a basic anion. So when you want to change the pH of the urine, you can give the patient the carbonic anhydrase inhibitors. So this is usually required when you treat patients with methotrexate, because methotrexate gets crystallized when the urine is very acidic. So in those cases, you need to alkalize the urine, and that is where carbonic anhydrase inhibitors are useful. And then it can be used for metabolic alkalosis, which is a side effect caused by excessive use of diuretics, especially the loop and the thiazide diuretics in severe heart failure. And it can be used in acute mountain sickness. How it acts is that when you go to elevated places, there's lower oxygen, and then carbon dioxide accumulates in our body, which is converted into bicarbonate, and it causes the phenomena called respiratory alkalosis. So carbonic anhydrase inhibitors prevent or counteract this respiratory alkalosis. Thus, it can be used for acute mountain sickness. And these drugs can be used in case of diuretic resistance. We'll know a little bit more about this in the last slides, but basically, if a patient is completely resistant to at least a single loop diuretic or a thiazide diuretic, adding this carbonic anhydrase inhibitors can elicit a synergistic effect among those two drugs. Now, looking at the toxicities, it will be on the opposite end of the spectrum from the indications. So basically, we are using this to treat metabolic alkalosis. So the toxicity would be metabolic acidosis, the other end of the spectrum. And the only way to treat that is to stop the drug. There's no other way to treat it. And another toxicity is formation of renal stones. So for example, if the urine is very alkaline, calcium phosphate crystals can be formed, and that would form renal stones. And then, like we saw, there's wastage of renal potassium and phosphorus, and you can also get drowsy or paresthesias at large doses. And then nervous system toxicity if accumulated in renal failure or hypersensitivity reactions. So these drugs, the structure is similar to sulfonamides. So they have hypersensitivity reactions, which are very similar to sulfonamide antibiotics, like rashes or photosensitivity, etc. Now, the contraindications are hepatic cirrhosis. So carbonic anhydrase inhibitors which cause alkalization of urine, that causes a urinary excretion of ammonium ions. And ammonium ion is converted into ammonia, which is very rapidly absorbed into the system. So the patient develops hyperammonemia and hepatic encephalopathy. So the contraindication is hepatic cirrhosis. And then you have to also be extremely cautious when you are treating patients with COPD, because they might have respiratory alkalosis. And then for monitoring, you have to obviously look at the potassium levels and the phosphorus levels. And the drug-drug interactions are salicylates. They usually displace the carbonic anhydrase inhibitors from the plasma proteins. So calcium, so the CAIs are excreted at a faster rate, so lesser effective. So here is a table with the dosage for the different types of indications for acetazolamide, and the dose is almost similar for it's 500 to 1000 milligrams per day for most of these indications. And I guess only the heart failure would require a IV treatment. Now let's look at the loop diuretics. Loop diuretics are one of the most efficient diuretics. So they prevent or they inhibit the sodium, potassium, and the 2-chloride channel. It's also called the NK2C cotransporter. So because it inhibits this cotransporters, there's increased excretion of the sodium and chloride. And usually under drug-free conditions, the potassium from the cell diffuses out and forms a positive luminal membrane, which drives the bivalent cations like the calcium and magnesium to be reabsorbed. But when this general phenomena is blocked by the loop diuretics, along with the sodium and chloride, all the calcium and the magnesium is also lost into the urine. From here, we see that the loop diuretics act on the ascending loop of Henle, and the excess sodium that is excreted reaches again to the tubules, where it is absorbed by the ENaC transporters, similar to the carbonic anhydrase enzymes, and then potassium is released into the tubules. So the major advantage with loop diuretics is that this is a large surface area, and about 25% of the sodium is usually reabsorbed from this area. So you're basically inhibiting all of that sodium reabsorption. This is more efficient diuretic than any other classes that we discussed today. And this action does not require the presence of bicarbonate like how the carbonic anhydrase inhibitors need. So these loop diuretics do not usually develop tolerance. So those are the advantages over calcium anhydrase inhibitors. So overall, they cause a loss of sodium and water, they cause hypokalemia, and they cause increased calcium loss. Also, they act by inducing the COX enzymes and inducing the synthesis of prostaglandins, and specifically the prostaglandin E2 inhibits salt transport in the thick ascending loop of Henle. So this is a minor mechanism of action in addition to this sodium-potassium channel blockage. Now the indications for loop diuretics are, because it causes extreme diuresis, it is used where acute pulmonary edema or any other edematous conditions are present. It can be used in hyperkalemia cases. Because it causes hypokalemia, you're using it to treat hyperkalemia. And you can use it to treat hypercalcemia. And you can use it to treat acute renal failure, especially with oliguria. That means where urinary output is very low. So in those cases, you can use loop diuretics and push or increase the urinary output, and also increase the potassium excretion. And it can also be used in anion overdose. Now, the toxicities of loop diuretics are hypokalemia and the associated metabolic acidosis, and then ototoxicity. So the sodium potassium chloride channels are also present in the ear, and since loop diuretics can block that as well, the adverse effect is ototoxicity, but this is reversible. And there's an important side effect is hyperuricemia, because loop diuretics and also the thiazide diuretics are secreted into the tubule. If that has to happen, the urate from the tubules has to be absorbed. So it is a co-transporter in the opposite direction. So it is called, the transporter is called the OATs, organic anion transporters. So this leads to accumulation of urate, or reabsorption and accumulation of urate. So hyperuricemia is caused as a side effect of thiazide diuretics. And then it can cause hypomagnesemia, thiamine deficiency in heart failure, pseudoporphyria or photosensitivity with furosemide. And like we can expect, severe dehydration can happen because there is excessive loss of fluid volume. Now, the contraindications for loop diuretics are hepatic cirrhosis, borderline renal failure or heart failure, and people who are diagnosed with gout. So gout is an extreme case of hyperuricemia. So the use of these drugs are contraindicated in those patients. And then furosemide and bumetanide are pregnancy category C, so they are risky. You can use torsemide instead, which is pregnancy category B. And then the drug-drug interactions, the NSAIDs and probenecid, they reduce the secretion of weak acids into the tubule. So it's basically a competitive inhibition that is happening between NSAIDs and the loop diuretics. So when you give them together, the loop diuretics are not excreted into the tubule and it doesn't work. And the NSAIDs, their mechanism of action is innately inhibition of COX action. But this is how it prevents the COX and prostaglandin side of mechanism of action of loop diuretics. And then other drug-drug interactions are with aminoglycosides or platinum-containing chemotherapeutics. It can exacerbate the ototoxicity that is caused by loop diuretics. And then drugs like digoxin and quinidine can exacerbate the hypokalemia that is caused by loop diuretics. So for monitoring, we have to monitor the ototoxicity and the hypovolemia and the associated weight loss, the glucose levels, and the electrolyte abnormalities. Now here is a list of dosages for the most used loop diuretics. So here we can see that furosemide, among others, are the most commonly prescribed drugs. Is the most commonly prescribed drug. And when we look at hypertension, it is loop diuretics are a second line drug. They are not first line. And then even for ascites in cirrhosis, it is given as an add-on to spironolactone, but it is never given as a first line drug. Now looking at thiazide diuretics. So this is one of the most frequently used diuretic, frequently used antihypertensive. It is also among the most frequently prescribed top 10 drugs in the US. Maybe top 12, but yeah, it is the most very highly prescribed drug class. So they act by inhibition of the sodium chloride channel in the distal convoluted tubule. So inhibition of this channel causes an increased excretion of sodium, and that is how natriuresis and diuresis happens. And usually this because of the inhibition, lower levels of sodium is formed within this tubular cell, which causes activation of the calcium and sodium channel on the basolateral membrane, which draws in the sodium from the blood to balance this negative, you can say negative anion pressure, cation levels. And then calcium is reabsorbed instead. So this is the difference between the thiazide diuretics and the previous loop diuretics, because in the loop diuretics we saw that calcium is inhibition of loop diuretics causes an excretion of the divalent cations, but in thiazide diuretics, inhibition of this causes intake of these divalent cations. So like we discussed, it acts on the distal part of the convoluted tubule, and all of the excess sodium that travels to the end of the tubule is reabsorbed by the ENaC channel, and the potassium is excreted instead. And about 10% of the sodium that is usually filtered is absorbed back at the distal convoluted tubule. So this, in comparison to loop diuretics, which act in the ascending loop of Henle, it can prevent the absorption of 25% of sodium. But here, thiazides can prevent the absorption of 10% of sodium. So these are moderate efficiency diuretics. So overall, the effect on sodium and potassium is similar to loop diuretics, but it acts in the opposite direction for calcium reabsorption. Also for thiazide diuretics, some studies hypothesize that they not only act on the kidneys, but they cause a mobilization of sodium and water from the arteriolar walls that relaxes the vessels and reduces the peripheral vascular resistance. And also, because their structure is similar to a drug called diazoxide, which is a vasodilator, the hypothesis is that they also act on the vascular smooth muscle cells. So these are some additional mechanism of actions for thiazides. And these thiazides are discovered to be an efficient form of the carbonic anhydrase inhibitors. But then they later realized that carbonic anhydrase inhibitors they just act on the bicarbonate ions, but this acts on the sodium and chloride ions. So they definitely have a different mechanism of action, but some thiazide diuretics do have a carbonic anhydrase inhibition activity. For example, chlorthalidone has a carbonic anhydrase inhibition activity. Now, the indications are they are the first line drugs in hypertension, and they are used in heart failure. They can be used in nephrogenic diabetic insipidus. And the toxicities include hypokalemia and hyperglycemia. The hyperglycemia, it was more significant when before 2006 or 2005 or before the JNC6, when people used to use 100 and 200 milligrams of thiazides to treat hypertension. But then later, after JNC6, they decided that 25 milligrams is sufficient to cause enough antihypertensive effect. So at that low dose thiazides, hyperglycemia has not been very clinically important. And then hyperlipidemia, about 5 to 15% increase in the levels of triglycerides and low sodium, low LDL cholesterol is found, but then this normalizes on chronic use. It can also cause hyponatremia, and then it causes hyperuricemia, similar to the loop diuretics, because excretion of loop and the thiazide diuretics requires reabsorption of urate into the blood. And then even thiazide diuretics have sulfonamide-like structure, so they also have hypersensitivity reactions to those drugs. And the drug-drug interactions include bendrofluam thiazide, because this class can cause calcium retention, like we saw. So you have to be careful when you're administering calcium supplements or vitamin D. And then it can increase lithium reabsorption and thus lithium accumulation. Drugs like NSAIDs and probenecid, which are competitive inhibitors, this is similar to loop diuretics. And then hyperglycemic agents, because it has a hyperglycemic effect, it is said that thiazides can reduce the effects of antidiabetic drugs. So you need to increase the dose of antidiabetic drugs when you give thiazides. Corticosteroids, alcohol, barbiturates, and narcotics are said to cause orthostatic hypotension if you give it with thiazides. And QT prolonging drugs can cause arrhythmias because of hypokalemia that is caused by thiazide diuretics, and which is exacerbated by the QT prolonging drugs. And the contraindications are similar to loop diuretics. It's hepatic cirrhosis, borderline renal failure, or heart failure. Now, these are some additional points which are very interesting for thiazide diuretics. So for thiazide diuretics are among the preferred first-line antihypertensive drugs. So you might remember this, the treatment chart from the American Diabetic Association from your previous classes here. So even for stage 1 hypertension or a stage 2 hypertension, the recommendation is to go with the first line drugs like ACE inhibitors, ARBs, CCBs, or diuretics, or you go with the combination of these drugs. But among these first line drugs, diuretics were found to be the most efficient. And this was found in the ALHAT trial, which was done, which was done sometime in 2002. They compared all of the first line drugs and compared the clinical efficiencies, blood pressure reduction, adverse effects, everything. And they identified that diuretics were able to reduce the stroke and cardiovascular morbidities and risks and reduce the blood pressure better than any other first line drugs. And thiazide diuretics are also the preferred combination therapy according to JNC7. But in the recent years, there is a dilemma of whether thiazide type or thiazide-like diuretics are better. So initially, they were thought that both these two classes are just the same. But just in the last decade, they identified that the thiazide-like drugs, example chlorthalidone, has a longer duration of action and better cardiovascular risk reduction potential. Um, and also it has higher potency. So the recent guidelines, the 2017 American Cardiology, College of Cardiology and American Heart Association guidelines on hypertension, they are recommending the use of chlorthalidone over hydrochlorothiazide. But this is not generally accepted in the research community because people still are using 95 hydrochlorothiazide, which is the classic thiazide, 95% times more than the longer acting chlorthalidone, just because it has less, it is more safer and it has lesser adverse effects. And all of the studies that prove this better cardiovascular risk reduction potential are all indirect studies, and there was no head-to-head comparison. So the debate is still going on, and this is one of my research topics as well. So here is a slide that talks about the doses and the doses of different thiazides in different indications. So the most important that you might want to remember is just hydrochlorothiazide and chlorthalidone. This is used 95% of the time, and chlorthalidone is being promoted more often now. But indapamide is also coming up. Chlorthalidone is considered 2 times more potent than hydrochlorothiazide. So the dose for chlorthalidone is 12.5 to 25, whereas for hydrochlorothiazide, it is 25 to 50 milligrams. Okay, so the important thing that you might want to remember is that thiazides are not recommended for heart failure where GFR is less than 30 milliliter per minute per square meter. And if required, it has to be prescribed along with a loop diuretic, but not alone. Now looking at the potassium sparing diuretics. So they act by, okay. Sorry, yeah. So potassium sparing diuretics act by, they prevent the potassium excretion, as the name suggests, by antagonizing the effects of aldosterone in the collecting tubules. So they can act either by the direct inhibition of this mineralocorticoid receptor, or they can inhibit the sodium influx channel. So the examples for those which inhibit the mineralocorticoid receptor are spironolactone and eplerenone, and those which block the ENaC channels are amiloride and triamterene. So reduced in sodium influx decreases the electrogenic exchange of sodium for potassium, and this can cause hyperkalemia and acidosis. And yeah, these act in the collecting tubule cells, so at the end of the nephron. And only about 2 to 5% of the sodium is filtered and reabsorbed there. So these are very less efficient diuretics. So overall, aldosterone antagonists cause a loss of sodium and water, hyperkalemia, and some risks of acidosis. So the indications are any conditions which causes a mineralocorticoid excess or hyperaldosteronism. So it could be primary, where it is genetic, or it could be secondary to hypertension, hepatic cirrhosis, nephrotic syndrome, or thiazide or loop diuretic induced hyperaldosteronism. So in those cases, you can use potassium sparing diuretics. And the toxicities are hyperkalemia and hyperchloremic metabolic acidosis, gynecomastia, because spironolactone is a synthetic steroid, so it acts as a steroid, and these adverse effects of steroidal adverse effects are less common with eplerenone, and then it can cause acute renal failure and kidney stones. The contraindications and drug-drug interactions are as follows. So chronic renal insufficiency. So you should not, this is important, you should not definitely use it with the RAS inhibitors, either the ACE inhibitors, it's ARBs, or the beta blockers, because it can exacerbate the hyperkalemic effect of this class. And dose adjustment is required in liver diseases. And strong inhibitors, CYP inhibitors like erythromycin, fluconazole, diltiazem, and grapefruit juice can increase the blood levels of eplerenone, but it does not affect so much on spironolactone. And spironolactone is pregnancy category C, along with the triamterene. But eplerenone is more safer, it's category B. So here is a list of dosages for various indications for aldosterone receptor antagonists and the sodium channel inhibitors. Now let's go with the osmotic diuretics. So osmotic, so you know what osmosis is, right? So if there's excess solutes and the concentration of the solution is higher on one side, and there is a diluted solution on the other side, and it is separated by a membrane, usually the diluted solution passes through the membrane so that a homeostasis is set up between the two sides of the membrane. So that concept is used by these class of diuretics. So basically, mannitol is nothing but a huge sugar molecule. So they are giving IV mannitol so that the lumen filtrate has a higher concentration of electrolytes or this liquid, and which draws out water from the tubules, and this water is released out. So this is not affecting electrolytes in any way, and that is why it is an aquauritic and not necessarily a natriuretic. So mannitol acts by loss of water, and it causes reduced intracellular volume, and it causes hypernatremia risk as well. And mannitol can act at several places, like the renal proximal tubule, the descending loop of Henle, and also close to the collecting tubes as well. So the indications are reduction of intracranial and intraocular pressure. Because the mannitol does not pass the blood-brain barrier, it is there in the cerebrospinal fluid, and it drains out the water out of the blood, out of the brain. So that is how it acts to reduce the intracranial and intraocular pressures. The toxicities involve obviously extracellular volume expansion, and that can cause edema and headaches and vomiting, and dehydration, hyperkalemia, and hypernatremia, and then hyponatremia in those with severe renal impairment. The contraindications are cardiac and renal insufficiency. Because mannitol is eliminated renally, it is very important that you have good renal function for it to work. Otherwise, mannitol just gets accumulated in the body, and it causes renal osmotic nephropathy, the accumulation of water in the kidney. So that is the side effect. Now, these are the doses for mannitol. It is available as an IV solution. It is also available orally, but then mannitol, because it is not absorbed from the gastrointestinal tract very well, if you give mannitol orally, it will just cause osmotic diarrhea and not osmotic diuresis, because it's not being absorbed into the body for it to act. So it is necessary that you have to give it IV. So here is a table comparing the electrolyte patterns and body pH for each class of this diuretic. So we can see that the carbonic anhydrase inhibitors acts more on the bicarbonates and has a little effect on the sodium chloride and the potassium, and it reduces the body pH. the carbonic anhydrase inhibitors and the potassium sparing inhibitors, they reduce the body pH. They are making it more alkaline. And the loop diuretics and thiazides, they increase the body pH. So loop diuretics, they only act on the sodium chloride part and maybe on the little bit on the potassium levels, but have no effect on the bicarbonate aspect. Thiazides, they have a moderate effect on sodium and chloride and minimal effect on bicarbonate and potassium. So when you combine loop diuretics and thiazides, you can get a combination of all of these three, and it is used sometimes in, I think, in ascites, refractory cirrhosis conditions. Yeah. So this is a table. We have gone through the doses already, but what I wanted to show is just the potency of diuresis for each class of diuretic. So the potency of diuresis is calculated by the percentage of sodium that is filtered by the kidney. So it's basically the ratio of the amount of sodium in the urine with the amount of sodium in the plasma. So, and that compared to the renal flow rate. So if you do those calculations, we can see that loop diuretics have a 20 to 25% efficiency, and the thiazide-like diuretics have 5 to 8%. Acetazolamide, the mineralocorticoid antagonists, and the amiloride have 4 to 2%. So these are less efficient diuretics. This is the highest efficient diuretic. So these are so we have covered all of the important ones. I'm sorry, I have somebody who's knocking at my door. I'm really sorry. Yeah, but I'm taking a call now. I might not be. Would you be able to come back after a couple of minutes? Okay. Yeah. Yeah. Thanks. Sorry about that. So yeah, we have covered the basic, the most commonly used thiazide diuretics. Sorry, commonly used diuretics. So these are some miscellaneous diuretics. There are antidiuretic hormone antagonists. So these are lithium and demeclocycline. These are previously used, but they are not used nowadays. They are non-specific antidiuretic hormone antagonists. And the most recent ones are Vaptans. They are the specific receptor antagonists. Examples are conivaptan, tolvaptan, lixivaptan, mozavaptan, and satavaptan. So the indications are syndromes where there's inappropriate ADH or the antidiuretic hormone secretion. The toxic effects are nephrologic diabetic insipidus, the acute renal failure, and chronic interstitial nephritis. And the newer diuretics, the SGLT2 inhibitors. So this, the sodium glucose co-transporter receptors, though these are known long ago, the inhibitors are just recently discovered, and these are basically anti-diabetic drugs, but then they also have diuretic effect, and that is why it is also discussed along with the diuretics in most of the pathophysiology textbooks. So sodium glucose co-transporter, the SGLT2, reabsorbs 90% of the filtered glucose along with the sodium ions from the proximal part of the convoluted tubule. So, so the first part. So inhibitors of SGLT2 causes both the sodium and glucose excretion. So they cause both osmosis and natriuresis. So the because it prevents the glucose absorption. So basically it is causing glucose excretion, and that is why it is indicated in diabetes mellitus as a third line agent. And only in 2020, these have been identified to be effective in heart failure, especially with reduced ejection fraction, heart failures with reduced ejection fraction. So studies showed that SGLT2 inhibitors produced a 3.2 kg weight loss, which is good compared to other antidiabetic drugs, which cause a weight gain. And it caused a 5.1 mm drop, sorry, this is a drop, in systolic blood pressure, and it causes increased urinary volume. And all of these weight loss and change in blood pressure are hypothesized to be diuretic effects. So examples are dapagliflozin, canagliflozin, empagliflozin, ertugliflozin, and ipragliflozin. The risks with this drug are increased incidence of fungal and urinary tract infections. And the drug-drug interactions are rifampin reduces the dapagliflozin exposure by 22%. So usually when you take a class of drugs, you do not combine, if you are giving a combination of drugs, you do not combine drugs from the same class. But because diuretics have different mechanisms of action, you can sometimes combine these drugs. So the combinations that you can use are loop agents and thiazides. So among those who are specifically refractory to just the loop diuretics or just the thiazides, these two drugs, because one acts in the proximal convoluted on the loop of Henle and the other acts on the distal part, if let's say one person is refractory to loop diuretics, that what is happening is, though there is inhibition of sodium by the loop diuretic, it is getting absorbed back into the system at the distal part. So when you inhibit the reabsorption at two places by using the loop diuretics and the thiazide diuretics, in those cases, the person will have a synergistic effect, not just an additive effect. It would be more than if you use one drug alone. And for this combination, usually metalazone is used. But when you're giving loop and thiazides together, because it affects potassium and sodium levels in the same direction, like it causes hypokalemia, both of them cause hypokalemia, and both of them cause hyponatremia. So you might have to check the potassium levels, and you have to check the hemodynamic aspects of it, like is the urinary excretion too high, because both of those diuretics are working together. So you cannot give a combination of these diuretics to outpatients. You have to have them inpatient and keep monitoring them clinically. And then potassium sparing diuretics and proximal tubule diuretics or loop agents or thiazides. So basically, potassium sparing diuretics can be combined with any other type of diuretics, because potassium sparing are acting in the opposite direction. So they counteract the hypo and hyperkalemic effects of these two classes. And then spironolactone, which is a potassium sparing diuretic, is usually combined with furosemide, which is furosemide is a thiazide. It is used in cirrhotic ascites. So to summarize, we have looked at different types of thiazides and their side effects and their uses, indications, and I hope it is slightly clearer. You might not remember each of them now, but then if you look at the mechanism of action of each of them, you will be able to derive the indications and contraindications for each of these. So that was my idea of having those detailed explanation for mechanism of action. And overall, diuretics usually should be administered sometime in the morning, or if a second dose is required, it should be given in the afternoon, but usually avoid nighttime doses because it causes nighttime nocturnal uresis. So you will have to the patient has to wake up at night to urinate. So that's not comfortable. And then for general monitoring purposes, for any kind of diuretics, you have to look at the fluid volume, the urinary output, the electrolyte levels, the body weight, and the acid-base status or the pH, the serum glucose, and BP. And these monitorings are very much important, especially among those with cardiovascular diseases, hepatic and renal diseases, or in elderly individuals. And the blood urea nitrogen and the creatinine might have to be calculated if there is hypovolemia, especially with those of loop diuretics. I guess that ends the lecture. I have a couple of questions for you guys. So can you pick which is an example of thiazide diuretic? I don't know if Ajit sir can see the answers.
Yes, we can see the answers. Yeah.
Okay. Oh, so what was the answer? Most of the people.
Actually, it is 1 minute late in. Okay, so people are people are answering 1, 2, 3, 4, 4, 1, 2, 3, 4. Okay, guys, answer 1.
So okay, you might wanna.
Yeah, wait, let them answer. Let's see how they answer things. Yeah.
Yeah.
So 4 people are.
So
Okay.
it is.
Most of the people are selecting bumetanide.
Sorry. So the bumetanide is a loop diuretic.
Exactly.
So something
bumetanide
with.
is not an answer.
Yeah. So it is metallazone.
It is metallazone.
Yeah.
Guys, you forgot the lecture now only.
No, it's okay. I didn't show the slide for long, so they didn't have time to remember the all of the drug names. It's totally all right.
Okay. So shall we move to the next question then?
Yes. So which drug causes hyperkalemia?
Yeah, I think they'll give the right answer here.
Do we have the answers?
2? No. Okay, people. Okay, guys, answer. Wait. They're answering. It takes a minute actually to reach there.
Okay.
Potassium sparing. Yes. People are answering 4. Yeah.
That is correct.
4 is the right answer, guys.
Yes.
Yes.
So hypokalemia is not a side effect of. So it's similar.
Wow. Quite complicated. Quite complicated.
Okay. So maybe I'll open that slide for you guys and then you can.
No. Let them answer first.
Oh, okay.
Let them answer first. Okay. Hypokalemia is not a side effect of.
Yes. So
Guys,
basically, we're asking which causes hyperkalemia, right?
Spironolactone 1. Yes.
Is this the question? Yes. You're all right. It's spironolactone.
It's
The potassium
spironolactone.
sparing diuretic. Yes.
Yeah.
So amiloride is an example of.
Wait, let them answer. Okay. Yeah. Okay, wait, let me check in YouTube what they're answering. Can you make it full screen?
Oh, yes, sorry.
Guys, no, yeah. Don't answer 5 number. 5 is not an answer. Oh.
It is.
Nobody's answering actually, Only one person has answered 5. Yes.
Yeah,
so right answer is 5, guys.
5.
Epithelial sodium inhibitors. Don't be confused. Guys, don't be confused. 5 is the right answer. Epithelial sodium inhibitors. Oh, people are answering 4. No. Aldosterone antagonist.
So aldosterone antagonists are spironolactone and eplerenone. So this
Eplerenone,
one
yes.
is below. I mean, I think the problem is because the mechanism of action is in the same slide. Maybe because that is why
Maybe.
people are
Yeah,
confused. They both are acting in the same part of the tubule, but
true.
it's just that one is acting on
No,
the sodium
not
influx and
not
spironolactone is on the
aldosterone
other.
antagonist, guys. Not
Yeah,
not aldosterone antagonist. It's epithelial sodium emitter, sodium
yeah,
inhibitors. Number 5.
yeah.
Okay, so shall we move to the next question?
Yes, sure. So diuretics working on ascending loop of Henle. This is an easy one.
Oh, I think it's quite anatomical question.
But I have given a clue here.
Yeah, yeah, of course. Okay, guys. So diuretics working on ascending loop of Henle. Wow. Yes. Answer is 1. Everyone is
Yes,
answering 1. Yes,
it
true.
is a unanimous
Because
winner.
loop is
Loop.
matching in the
Yeah,
question and answer.
exactly.
Yeah. So loop diuretics.
So which diuretics work on the collecting duct? That means at the end of the tubule.
End of the tubule. Yeah. Mhm. So guys, next question is coming in YouTube in a minute. Wait. Yeah. Diuretics working on collecting duct. 4. Potassium sparing.
4, correct.
Potassium
So
sparing. Yes.
correct. The loop acts on the loop. Thiazides act on the distal convoluted tubule.
Yes.
Osmotic diuretics act like across, and
Across
then potassium sparing act on the last part, the collecting
last
duct.
part. Yeah. Okay. Yeah. Answer is 4. Do we have
Yes.
any other question?
No, that's all I had.
That's all.
Yes.
Great. It was a fun. So, how was the class, guys?
Wow. I hope I have not confused everybody.
No, you are getting very, a great feedbacks, and it was really a nice class. It was really a nice session.
Yay.
Yeah. Okay. So I will read few of the feedbacks right
Okay.
now. Okay. Let me go up. Uh, yeah. One sec. Continue. Oh, I have to go a lot. Wait. Informative, detailed, explanatory. Thank you. Class was amazing. Really nice. Such a nice class. Very helpful. Simplified. Very nice session. Sir, please use Airtel 4G. Oh, I'm using Geo 5G. Very informative, very informative. Wow, amazing, very informative and explained session. Amazing. It was detailed, but it was simple to understand. It was really great.
Yay.
Very informative, ma'am. Very informative. Thank you. Very nice class. Thank you very much for this wonderful class.
Thank you guys for
I think
listening to this long
somebody is advertising Airtel 4G here.
lecture.
Really important. It was interesting. Learned many new things. Wow, such an informative class. Thank you. Okay, so guys, we will just if you have any questions to Mansha, you can ask right now. She'll be
Yep,
happy
yep.
to answer, and then we will take off. We'll just go off because she did not sleep whole night and she was preparing the class, guys. I'm telling you, she was awake whole night to prepare this class.
Yeah, that was my bad. I received the information a week ago and I have worked on the last day. So my bad.
No, but it was amazing class. Seriously, it was amazing.
I'm happy.
Yeah. Okay, so I think no questions. Right,
Okay,
Mansa?
so
Thank
everything
you
is
very
very
much.
clear.
Yes, you go have breakfast and have a good sleep. Thank you very
Yes,
much.
I will.
Yes.
Thank you, guys.
Thank
Bye.
you. Bye bye. Bye bye. Take care.
Yeah.
Yeah. Bye bye.